Ashutosh, you can start now.
Yes, sir. So, good evening, everyone, and a very warm welcome to today's ICP Clinical Case Dialogue session, a unique academic initiative focused on interactive, case-based learning and practical clinical decision-making. At the outset, I extend my sincere respect, full regards to Honorable Dean ICP Dr. Girish Mathur sir for his visionary leadership and continued encouragement towards such academically enriching programs. I also offer special thanks and regards to Dr. K.K. Parikh sir, Dr. G. Narsimulu sir, President API, Dr. Ashok Taneja sir, President-elect API, Dr. Jyotirmay Paul sir, past President API, and Dr. Puneet Saxena sir, Honorary Secretary of API, for their constant inspiration and remarkable contribution to ICP initiatives. Dear delegates, today's discussion on a case of chronic liver disease, how to prevent readmission, addresses an extremely relevant and challenging area of clinical practice. We all know that preventing repeated hospitalization in chronic liver disease requires treatment strategies, comprehensive patient care, timely follow-up, nutritional support, and multidisciplinary approach. So today we are privileged to have an eminent academic panel with us this evening. A warm welcome to our moderator, Dr. Nandini Chatterjee, Dr. Dujen Das, sir, Senior Governing Body Member of API, and convener, Dr. Nandini Chatterjee, Madam, Editor-in-Chief of JAPI, for organizing and guiding this important dialogue in a very short notice period. I also warmly welcome our case presenter, dear Dr. Rohit, and our distinguished panelists, Dr. Anup Kumar Das, sir, Dr. Pradeep Kumar Bhaumik, sir, and Dr. Bhaskar Jyoti Barua, sir. All are renowned names in their specialties who will enrich today's session with their valuable experience and practical insights. I am confident that this interactive discussion will be highly engaging and beneficial for all participants. With this, I now request our Honorable Dean, Dr. Girish Mathur, sir, for his kind words.
Good evening, friends. Dr. Nandini Chatterjee, Editor JAPI and convener of this program, Dr. Dujen Das, distinguished faculty of the evening, Dr. Anup Kumar Das from Dibrugarh, Dr. Pradeep Bhaumik from Agartala, and Dr. Bhaskar Jyoti Barwa from Guwahati, Dr. Ashutosh, and I also welcome Dr. Rohit Kumar, who will present this case today. So it's my pleasure to extend a warm welcome to all of you on behalf of Indian College of Physicians to another engaging session of ICP Clinical Case Dialogues, our case-based discussion series dedicated to fostering practical learning and clinical excellence through real-world patient scenarios. This session will focus on a case of chronic liver disease, how to prevent readmission, highly relevant topic that addresses one of the major challenges in the management of patients with chronic liver disease. The program is being convened by Dr. Nandini Chatterjee, whose commitment to academic excellence continues to enrich ICP's educational initiatives. The session will be ably moderated by Dr. Dujen Das, who will guide the discussion and facilitate meaningful clinical deliberations. We are privileged to have eminent panel of experts, Dr. Anup Kumar Das, Dr. Pradeep Bhaumik, and Dr. Bhaskar Jyoti Barwa. Their vast clinical experience, expertise in hepatology and internal medicine will undoubtedly add immense value to the discussion, offering practical pearls and evidence-based perspectives for everyday clinical practice. Case-based learning remains one of the most effective methods of medical education, bridging the gap between theory and practice while enhancing clinical reasoning and decision-making skills. I am confident that this session will stimulate thoughtful discussion and provide participants with valuable take-home messages applicable to patient care. I wish the program a grand success, and I wish a highly enriching and learning experience to all participants. Thank you so much. for joining this evening. Over to Ashutosh.
Thank you so much, sir, for your kind words. And I now welcome our convener, Dr. Nandini Chatterjee, madam, once again, and hand over the mic to her for the further management of this session. Thank you, ma'am.
Thank you very much, Ashutosh, and welcome and good evening to all. Today, the case that has been chosen, that is chronic liver disease, is being encountered in every OPD, every IPD by physicians, students alike. And it is very important to understand the nuances of management of such a case. The specific area that our panelists and our discussion will point to this evening is how to prevent readmission, because we know that these patients come back with one complication after another and their mortality is very high. So I hand over the mic to Dr. Dijen Dash, who will be moderating and will be guiding the discussion today along with our esteemed panelists. So Dr. Dijen Dash is the head of the department of Tejpur Medical College, along with being a senior governing body member of API. So Dr. Dash, please take over and let us begin.
Thank you. Thank you, madam.
Good evening, sir.
Good evening.
Now I mute all the delegates and unmute the faculties and moderators.
Yes, yes. Thank you. At the very
Please unmute, Dijen. You are muted.
Dr. Dash.
yes. So thank you very much. Good evening to everyone. At the very beginning, I'd like to thank our Dean ICP, Professor Girish Mathur sir, for allowing us to be in the screen. I also like to thank Dr. Ashutosh Chaturvedi for conducting the session, and also like to thank Nandini madam, who is convening this the clinical case-based dialogue. Now today we have got a panelist with us, Professor Anup Kumar Das, who is my teacher also. He is a professor Assam Medical College, Dibrugarh. And we have got Professor Pradeep Kumar Bhomik sir, known to everyone. He is also governing body member. He is Agartala Government Medical College. And I have got my younger brother, Bhaskar Jyoti Borua. He is a renowned gastroenterologist. He is the Associate Professor, Department of Gastroenterology, Guwahati Medical College. So I first begin with to present a short case by our postgraduate, Dr. Rohit. Rohit, you can share your slide and present the case.
Okay, sir. So, is the screen visible, sir?
Yes, you have to make it full screen.
Okay.
Yes, you can go ahead.
Shall I start, sir? First of all, good evening to all the respected and esteemed panel members, my moderator and my mentor, Dr. Dijen sir, all my respected seniors and my colleagues. First of all, I would like to thank you all to give me this opportunity. Today, I am presenting a case on decompensated chronic liver disease, preventing hospital readmissions. Note after the discharge of a patient, this is a patient-centered approach. Why this case is important? As we all know, DCLD, DCLD is a major challenge in our clinical practice because majority of the patients, around 30 to 50% of patients, get readmitted within the 3 months of the duration. This readmission increase the mortality and increase the healthcare cost, and this is reduce the quality of the life of patients. Many of these readmissions are potentially prevented through proper discharge planning and the patient educations. The key question here is not merely how to discharge the patient, but how to keep them well after the discharge. So here I start my case. A 43-year-old male from Bishwanath, formally educated up to 12th standard, a driver by occupation, presented to us with the chief complaint of distension of abdomen for 10 months, swelling of both limbs for 8 months, with decreased urine output for 1 month. On elaborating the history, patient gave history of abdominal distension, which was insidious in onset, painless, progressive, and symmetrical over 10 months, with progressive loss of muscle mass. The swelling of both the lower limbs are started after the development of abdominal distension, which was insidious in onset, gradually progressive from feet and ankle to up to knee joint. The leg swelling is present throughout the day and better on lying down position, leg elevation, and with after taking medications. There is progressive decreased urine output for 1 month, both in frequency and volume. There is no associated history of dyspnea, palpitation, chest pain, redness of the limb, high colored urine, frothy urine, facial puffiness, or other nephrotic drug exposures. There is no history of confusion, altered sensorium, hematemesis and melena, fever with cough or arthralgia, bleeding gum, diarrhea and vomiting or constipation, orthopnea, or there is no any suggestive history of PND. Patient gave history of prior hospital admission 2 times within the last 10 months with similar complaints. Patient after primary stabilization was discharged on oral medication, but each time the patient discontinued the medication in between the admissions. There is one episode of jaundice 4 months back that is managed by local traditional rituals. There is no associated history of any hypertension, diabetes, thyroid disease, tuberculosis or TB contact, or any other major illness. There is no significant past history of any blood transfusion, tattooing, or any injectable drug use or other high risk behavior. There is no similar complaint among the family member, no hereditary liver disease reported. There is no sudden cardiac death or other major family illness. Patient lives with his mother, wife, and 2 children, and family member all are in healthy state. Patient give a history of ethanol intake for 20 years. He used to consume around 200 to 300 ml of country liquor daily, often on an empty stomach. However, he stopped drinking alcohol about 10 months ago after the appearance of symptom after falling ill. He is a non-smoker. His diet is reduced. Patient is on eating non-vegetarian, normal Indian average diet. There is a significant history of sleep disturbance at night with daytime sleepiness since last 1 week. Patient was prescribed oral medication after discharge. There is partial symptomatic relief after taking medication. Then patient by himself discontinue the medication. There is no other herbal medication intake. There is no known drug allergy. No documented childhood immunization history was there. Patient received 3 COVID-19 vaccines. So the case summary here is a 43-year-old gentleman that is non-diabetic, non-hypertensive, presented with history of significant ethanol intake, with abdominal distension for 10 months, pedal edema for 8 months, along with reduced urine output. He had an history of hospitalization 2 times with similar illness. He has an episode of jaundice 4 months back without any history of hematemesis or melena, diarrhea or constipation, pain in abdomen, or any evening rise of temperature.
Okay, Rohit.
Yes, sir.
So, based on this,
Yes, sir.
so what will be your provisional diagnosis if you sum up the history? The
Sir,
panelist will also help you out to know.
yes, sir. Yes, sir. Yes, sir. Sure. As the patient showing chronic symptoms such as distension of abdomen for 10 months, pedal edema for 8 months, urine output for last 1 month. There is chronicity of symptoms, sir. So there must be a chronic illness. Patient also shows history of decrease in muscle mass over the time during the course of disease. So we have to suspect a chronic illness should be there. And other sign of portal hypertension, such as distension of abdomen or presence of fluid may be there. So our first and most probable diagnosis will be an alcoholic related cirrhosis with ascites or AKI. Another one is viral hepatitis related cirrhosis. However, there is no history of any IV drug use, no history of any blood transfusion, no history of any other toxic, high risk behavior. Another is there may be a non-cirrhotic portal hypertension or portal vein thrombosis. Hepatocellular carcinoma may be there with background of cirrhosis, abdominal tuberculosis, maybe abdominal malignancy also, and cardiac cirrhosis, one of the important differential of this case, sir.
So, sir, sir, mere presence of alcohol intake sufficient in amount. Do you think that this is only possible cause that it is because of alcohol, or maybe something else? You can go back in the slide.
Yes, sir.
Does, sir?
Sir, you have to unmute.
Bhaskar can also answer, no problem.
Yes, sir. Basically, good evening, ma'am. So basically, this patient is 43-year-old and he has history of alcohol intake for last 20 years, Rohit. Am I right, Rohit?
Yes, sir.
Yes, yes.
So that is quite a long duration.
Yes,
and
sir.
he has been taking country-made liquor.
Yes, sir.
So some studies have shown that compared to the Indian-made foreign liquor, IMFL, the country-made liquor has got higher content of alcohol.
Yes, sir.
Some of them may have alcohol up to 60%.
Yes, sir.
So he has been definitely taking a significant amount of alcohol intake. So if you see the data, he has fulfilled the criteria to have significant alcohol intake. So definitely we need to think this as the first etiology in our patient case. So he has definite features of liver dysfunction in the form of ascites and underlying cirrhosis. So alcohol will definitely think about as the first etiology. But thing is that in Indian subcontinent, hepatitis B should not be actually forgotten. It is also very important etiology in chronic liver disease. And he is 43-year-old. And one thing, Rohit, you have not told us about his vaccination history. That is very important in this patient.
So,
whether he has
vaccination history, sir, there is no any childhood significant history of vaccination, sir. No documentation is available.
That is very
Only
important.
COVID
actually.
vaccination history. Sir.
Because he might not have taken hepatitis B vaccines actually during his childhood.
Yes, sir.
Also, alcohol and hepatitis B or C, although there is no history of blood transfusion or any high risk behavior, but these are, I think, one of the most important etiology in this patient.
Here, Rohit,
yes,
I'm just interrupting. As a third differential, you have written portal vein thrombosis or non-cirrhotic portal hypertension.
Yes,
So can you tell us what is the common presentation of such patients?
Ma'am, this patient presented with the ascites, ma'am, one of the main important features, along with others.
No, I am asking, what is the common presentation of extrahepatic portal hypertension? And is it matching with what this patient has presented with? That is the
most common cause are, ma'am, infection in extrahepatic. Infection history we have to rule out. Other coagulopathies, ma'am.
No, presentation.
Presentation,
that your patient has mainly presenting with large ascites, which should not be the presentation of the extrahepatic. Usually, a young male will come with a massive hematemesis, usual presentation.
Yes.
or they may have some history of some sepsis in childhood. Most of them may not give that history. That is the presentation. Here,
Yes.
with so much ascites, I think this DD will have to come much later.
Later, yes.
Yes, ma'am.
Much later.
Because the childhood umbilical cord sepsis is one of the important causes of that.
And
Yes,
ascites is not very significant in this
Yes,
patient. They have got
that is the negativity.
they have got preserved liver function. So ascites we rarely see in patient with NCPF or ESPVO.
Yes, yes.
yes,
Can it still be a case of abdominal tuberculosis?
Yeah.
yes, sir. We have to suspect. However, the usual constitutional symptoms such as fever, night sweats, these are absent, sir. And contact history also not there. But sometime the history patient is giving is not
Not
significant, sir.
dependable sometimes.
Yes,
And
sir.
he
He
has
may
weight
miss
loss.
sometimes, sir.
This patient has weight loss.
Yes, ma'am. Progressive weight loss and decrease in muscle mass is there, sir.
Actually, can you tell how many times more a CLD patient is prone to tuberculosis than the normal population? How many times more predisposed they are to have tuberculosis? They
Yes,
are
ma'am.
Huh? Bolo?
It's a chronic illness, ma'am, immunosuppressive state.
No, they are very prone, like almost 14 times more probably to get TB, CLD patients. And there is a lot of confusion in the ascites, whether it is due to peritonitis or anyway, let us, I think, progress.
Yes,
Dr.
ma'am.
Can please take up.
Yeah. So go to the next slide. Bhomik sir and Onubdas sir will be there. So would you think that this case, why do you think that this is because of ethanol? That's what I'm asking, because Bhaskar has said there is every ground to think that this patient is having ethanol-related chronic liver disease. But literature says that 10 to 20% of those who are actually fulfilling the criteria of taking adequate amount, adequate duration, that means 20% can go to develop cirrhosis, say it may be 25%. Why are you blaming that alcohol here? Is there any ground to think other than the history of intake?
Sir, chronic history was there, sir, and significant amount of his ethanol ingestion was there. Along with, sir, other significant factors such as viral hepatitis, these are absent in this patient, sir. And
From the history, it's difficult to say that there is no viral
Actually,
hepatitis.
hepatitis C, it is something which remains hidden
yes,
unless
ma'am.
you test. Okay. So,
Yes, ma'am.
Okay. So how can you differentiate a swelling or abdominal distension or leg swelling, whether it is a cardiac in origin or it is renal or it is hepatic? Just for the postgraduate, because this is, I think it's important to know.
Sir, as is this patient, there is no history of any dyspnea, orthopnea, or any feature that suggests of PND, sir. So, less likely for cardiac cause, sir. And renal, there is no any evidence of facial puffiness or no evidence of any hematuria, sir. No frothy urine, sir. And no other sign that suggests other nephrotic disease or other renal disease, sir. And vitals.
Pradeep
you have
sir,
oliguria, no? This patient has
yeah,
developed recent onset oliguria.
oliguria.
No, yeah.
Yeah, but the other things are not good. Yes.
Yes, ma'am.
I have got a. May I please?
Yes, sir.
Of course, sir.
I would like to take it in a different way. It's very simple. That is a case of chronic liver disease, no doubt about it. A patient has a history of 10 months, chronic ethanolic, and having the probably from a poor socioeconomic background. Consider all these things as a chronic liver disease. Second possible renal disease can be considered, just for the sake of the discussion. The chronic kidney disease can be the second differential diagnosis. 10 months tuberculosis is very unlikely. So I think this history is very, very important. The 10 months duration is chronic liver disease with some sort of anasarcum. But second important issue is etiology. When we discuss about the etiology, it is the epidemiology is very, very important. If you see that now in 2026, the commonest cause of chronic liver disease is either alcohol, particularly in Northeast or Indian context. Second is MASLD, or it can be, I mean, both of them are fighting very neck to neck, whether it is MASLD or it is chronic alcoholic liver disease. B has gone down significantly. C, we get only in cases of drug abuse and other frequently those who are taking blood transfusion. So, or some people who are very elderly, 70 years or plus. So, in that case, it is definitely alcoholic liver disease. Regarding significant alcohol liver disease, the definitions are variable. There are many societies, American societies, Asia Pacific societies, they take it differently. But if you ask me, I will tell you, okay, someone who is taking 2 packs of alcohol, that is almost 60 ml per day, 40% alcohol, that is 38 to 40% alcohol, at least 5 days in a week, at least more than 5 years, will take it as a significant alcoholism. And almost it matches to that. So this is a alcohol-related chronic liver disease. It is decompensated because he has already developed ascites and it is persistent. He had jaundice earlier, so probably he had a SCLF or acute chronic liver failure, and he has got edema fit, and also he has got significant sarcopenia. So he is already decompensated in many sectors. Many sectors. So it is a alcohol-related chronic liver disease decompensated with ascites and sarcopenia. That is the whole diagnosis. So at this stage you should consider. Yes, third issue is that renal failure, whether the patient is having AKI or not. That can be answered only by investigation, but only history that having decreased urine output may not give us a very clear-cut idea.
Sure,
because
sure.
he is not having breathlessness. A patient having AKI or CKD or AKI for 1 month, not having breathlessness, not very likely. And that is my impression regarding the case.
Thank you, sir. Sir, another question comes nowadays. You do see that the binge drinking is probably causing more harm than of regular small quantity drinking. Is there any inference on that?
Yes, there are many, I think, evidence that there binge drinking is always bad, and particularly it precipitates acute on chronic liver failure. Sometimes it is more related with even pancreatitis. Sometimes if a patient takes alcohol today, after 1 or 2 days, they develop acute pancreatitis. Probably it has got a good relationship with the pancreatitis too. But yes, binge alcohol is always bad than the chronic alcoholism. But it is not that you take chronic, 2 packs every day and enjoy. At a point of time, you will definitely develop chronic alcoholic liver disease. Another issue is why every alcoholics are not developing chronic liver disease. There are multiple factors, multiple genetic factor has been studied. We have also had a long-term study on these genetic factors in alcoholic liver disease. But there are multiple SNPs has been evaluated. But no specific gene could be found very specifically. So it is very difficult to say which gene is responsible and why it is more common in Indians, less common in Western people. Probably this question is still unanswered.
That is
Thank
an very, very interesting observation by Pradeep Bhumi. Can you hear me?
Yes,
Yes,
sir.
Yeah. So the point is that alcohol has become the commonest cause of CLD and cirrhosis globally. But the thing is that we are discussing how to prevent readmission.
Sure.
Okay.
Yes.
So, and there has been these 10 gram per day, 14 units per week, significant drinking, and all these things. These things are being challenged now, especially from studies from UK, that no, there is no limit which can be set up as your safe drinking. There is nothing called safe drinking. And regarding these genetic studies, one gene has been found to be protective of cirrhosis in heavy drinkers. As you said, only 20% of significant alcohol intake leads to cirrhosis. The other 80% are not. So this is a dilemma, but there has been some advances in the genetic things. Now, since this is, of course, as all of you have said, this is definitely related to ethanol damage. Okay.
Yes.
But we must remember one point or 2 points. That number one, whenever there is cirrhosis, it's not a single organ disease. It's a multisystemic disease, and it is a chronic inflammatory condition. So these two things we tend to forget and concentrate only on the liver. But we must always, especially in this case, examine the heart, because alcoholic cardiomyopathy, we miss so much. And
Sure.
that is the importance whereby we can prevent some deaths in alcohol-related cirrhosis, and also we can improve the quality of life of these patients if we find out that other organs apart from kidney and brain and heart is also examined thoroughly in ethanol-related cirrhosis of liver to prevent sudden cardiac arrest.
Right, sir.
That is why, how will you differentiate cardiac or renal cause? It needs investigation. We just can't rely on history, because the history will, as Dr. Bhumik has said, history is very common in both cirrhosis and these cardiac and renal causes.
Thank you, sir. Thank you. Rohit, you can go ahead.
Yes, sir. Sure, sir. So, on general examination of the patient is conscious, cooperative, well-oriented to time, place, and person. Patient is thin built, poorly nourished, with a BMI of 17.5 kg per meter square. Pallor and edema is present. There is no icterus clubbing, cyanosis, lymphadenopathy. Pulse rate is 84 per minute, that is regular. BP is 100 by 64 millimeter of Hg. Respiratory rate is 16 per minute and JVP is not elevated. Here you can see on general examination, the hepatic phasis is present, temporal fossa hollowing is there. Then there is atrophic glossitis, poor oral hygiene with multiple dental caries, and there is dry and scaly skin. And on bilateral lower limb, there is hyperpigmented excoriated patches or dorsum of both foot. There is sparse axillary and pubic hair, no parotid gland enlargement, spider navy, gynecomastia, no dupuytrenine contracture or palmar erythema, no testicular atrophy or astraxis. Is malnutrition, pallor edema, sparse sexually hair? But
So these are the only
yes,
findings that you have found in general survey,
yes,
right?
sir.
So positive findings are patients is having malnutrition, pallor, edema, and sparse secondary sexual hairs. So
Yes, sir.
based on this, can you think of some diseases? Sir, Onubdas sir, can you highlight?
This is very surprising that he hasn't found out at least parotid enlargement, because
There was no-
parotid enlargement is very, very common in your ethanol-related chronic liver disease, which is especially in child C cirrhotic patients. And this edema can be explained, pallor can be explained. Pallor has got importance in CLD because there are multiple causes of pallor in CLD.
Yes, sir.
And malnutrition is expected. Alcoholic patient itself, alcohol itself causes malnutrition, and the cirrhotic patient will have malnutrition. And secondary sexual hair again goes in favor of advanced liver disease, if
Yes.
at all it is due to the liver disease. And but palmar erythema, dupuytren's contractures, and these are a little bit less. Spider nevi also a little bit less because we are dark skinned.
Yes.
And but parotid enlargement, it's very surprising that there is no parotid enlargement, because we do find parotid enlargement in large number of alcohol abusers with
Yes.
CLD.
Yes. So one reason may be there.
What?
He has stopped alcohol 10 months back.
Yes,
10
yes,
months
yes.
back. But
That may be
there is a sentence in Robbins' pathology that alcoholics are the biggest liars in the street. It is written actually. Anyway, he has stopped. And parotid enlargement occurs due to what? Due to lymphocytes.
Yes.
Lymphocytes and infiltrating. But why
Yes.
this infiltration into the parotid, Bhaskar? Do you know? I don't know. That's why
No,
I'm
sir.
asking.
I think one issue is that patient BMI is very less.
Yes,
It's
sir.
17.5 probably. She
Yes,
shows that all these features might be due to malnutrition, not due to alcohol-related liver disease. That might be the explanation in this particular case.
Okay,
Yes, sir.
maybe.
Go ahead, Rohit.
Yes, sir. So,
The
this
other
as we
conditions can be
discussed.
this, yeah.
Yes, sir.
Okay.
So
Go
on
ahead.
inspectory findings, the abdomen is grossly distended, tense with fullness of flanks. Umbilicus is everted. Maybe probable there is umbilical hernia underlying. Dilated superficial abdominal veins. There is a stretched shiny skin and a paracentesis mark seen in the right iliac fossa. There is no other visible scar, sinuses, any peristaltic or pulsation. Um,
Now,
so,
when you
No,
mention such
Can
veins,
yes, ma'am.
yeah,
can
you
we go
have
back?
to,
Yes, ma'am.
sir, you have to say
Sorry,
the
sorry.
flow of veins. What was the direction of flow of these veins?
He will be describing in palpation, madam.
Palpation.
Oh,
Away
it is
from.
later on you have described. Okay,
Yes.
okay, go on.
Just
Anupta, you are saying something.
yeah.
Yes.
There are tense ascites, umbilicus everted with probable umbilical hernia. So this point, whether this is a hernia or a omphalocele, that is very important because one of them is a definite indication for liver transplant. So omphalocele and umbilical hernia should be differentiated from each other. And this paracentesis marked in the right iliac fossa. Actually, nowadays guidelines say that you should probably do paracentesis the left
The
iliac
left
fossa,
side.
not in the right iliac fossa,
Yes,
because
sir.
of that cecum, which
Yes.
becomes
Distended.
distended in chronic liver disease. So that were the 2 points I would like to.
Sir, in presence of 10 societies also, is it feasible to do it even in the right side? Because all the intestine coil will be suppressed down.
It's not in the right side. It should be in the left side, left iliac fossa.
Okay. Okay.
There are other reasons also, but this is for practical point of view. I'm saying this.
Okay, sir.
There are other reasons also.
Yes, sir.
Please go ahead.
So,
So there may be certain scenario, Rohit,
yes,
where
yes.
the patient may have abdominal distension, but flanks are not filled up.
Yes, sir. There may be possibility if the fluid is insisted, sir, and if underlying some large ovarian cyst or full bladder, and if in pregnant female patients, polyhydramnios can present with the gross abdominal distension without any fullness of flanks, sir.
Yes, yes. Yeah, go ahead.
So, on palpation, the abdomen is tense, uniformly distended, and non-tender. Liver is not palpable. Spleen and kidney are also not palpable. Umbilical hernia with an expansile cuff impulse is there. Direction of flow in the veins is away from the umbilicus. Fluid thrill is present. However, there is no other palpable intra-abdominal mass. On percussing, the shifting dullness is present with trop space dull to percuss. Upper border of liver dullness is found out to be in fifth intercostal space along with mid-clavicular line on expiration, and lower border of the liver is couldn't be appreciated, sir.
If you have the
Yes,
flow of veins, the flow of blood below the umbilicus, it is going from below upward. What will you think?
yes, ma'am. IVC obstruction, ma'am. One of the.
You will think about IVC obstruction. And what will be the flow of veins in SVC obstruction on the upper part of the abdomen?
From above downward, ma'am.
Yeah. So the flow can give us idea about the different vessels.
Involvement, ma'am.
Okay, go on.
Yes, ma'am.
So, Rohit, what do you expect if you suppose that there is fluid thrill? What does it signify? Other than ascites, any other condition where it get?
Sir, we are expecting fluid thrill when there is large amount of fluid, and fluid should be in tense state, sir. Maybe free fluid or maybe insisted fluid, sir. And we got fluid thrill in first tense ascites, sir. Then ovarian cyst, sir. We can find it on ovarian cyst or polyhydramnios, sir. And full bladder, sir. Full urinary bladder can also give fluid thrill, sir.
Yes, yes. So, Bhaskar sir? Would you like to throw some light about tender hepatomegaly ascites and the condition where you will get cirrhosis, ascites, and palpable enlarged liver?
Yeah. So sometimes we take it as a very important point to differentiate regarding the etiology when we get cirrhosis, ascites, and a palpable liver. So normally studies have shown that people with specifically alcohol-related cirrhosis, and sometimes in recent times metabolic dysfunction related liver cirrhosis, they have got palpable liver even if they have cirrhosis. And this is a distinguishing point to differentiate from viral hepatitis related cirrhosis, where we won't get a palpable liver.
Yes.
Additionally, if there is malignancy, like there is liver cirrhosis, on top of that we have got liver hepatocellular malignancy, then we can also have a palpable liver with ascites and liver cirrhosis. And I think these are the important points in cases of this palpable liver and ascites and cirrhosis.
Okay.
And tender hepatomegaly ascites, sometimes in cases of acute viral hepatitis, we may get ascites, but not in that significant amount. We may have mild ascites, but otherwise we don't get such a big ascites in acute conditions.
Yes, yes.
And if there is hepatic malignancy, then also we can have tender hepatomegaly ascites.
And right heart failure also you can get.
Cardiac
Yeah, right heart failure also we can get.
And also
Yes.
probably venous obstruction,
Yes,
outflow
yes, sir.
obstruction.
Acute Butt-Chiari syndrome, acute Butt-Chiari you can get.
Acute Butt-Chiari, we get tender liver and ascites, large ascites.
Yes, sir. Yes, sir.
And the palpability of MetLD or MSLD or alcohol-related chronic liver disease, when the liver is palpable, the explanation is probably fatty infiltration,
Yes.
steatosis in the
Steatosis.
surviving liver.
So as like in glycogen storage disease because of the deposition and
yes.
all, amyloidosis related in those conditions.
Correct.
Go ahead, Rohit. So these are the list. Go back. These are the list where you can get the enlarged liver with cirrhosis. Okay.
Sir.
Yeah.
Next.
Sir.
Shifting dullness was present. What does it signify?
Sir, there must be a free fluid, sir, in peritoneal cavity to elicit shifting dullness, sir. Or
any other region other than free fluid in the peritoneal cavity where you can get shifting dullness?
Yes, sir. False positive we can get in, sir. Paralytic ileus, sir. Without any fluid, we get, sir. And high bowel enema, sir.
Yeah, we can get in just after high bowel edema. Sir, can you get it, Pradeep Bhomik, sir?
Yes, yes.
Yes, sir. What is unilateral shifting dullness, Rohit?
Sir, in some case scenarios such as splenic rupture, sir, in left upper quadrant, the after splenic rupture, blood get clotted, sir. So when we are eliciting the dullness, there is no any shifting of fluid, sir. However, in case of hemoperitoneum in right upper quadrant, sir, the blood is in that case we can get, sir.
Yes, because of a splenic rupture,
Balance
what happens?
sign, sir, while
Yeah. There may be the clot of the blood may remain in the left side, and serum gets separated and they
Yes, sir.
are free. So
Yes,
in the
sir.
left side you may get dull node, but
Yes,
on the
sir.
right side because of the serum you may get shifting. So that is what
Yes,
is
sir.
known as balances sign.
Yes, sir.
Okay, go ahead.
Yes, sir. Sir, on auscultation, bow sounds are present but sluggish. There is no any arterial bruit or venous hum, sir. On other system examination, central nervous system, higher mental functions are normal. There are no flapping tremors, sir. There is no any constructional apraxia. And MMSC score was 13 by 13, sir. On cardiovascular system examination, the S1 and S2 are heard normally. No other murmur was heard. In respiratory system, normal vascular breath sounds heard bilaterally. No another added sounds. and genitourinary system was also normal, sir.
So you have not
Did
got
you,
any cardiovascular involvement. Yes, madam. Yes.
did you check the saturation of this patient?
Yeah.
Yes, ma'am. I
You
forgot
have
to
to,
mention, sir.
yes, in case of CLD,
Yes,
you
ma'am.
have to mention about the saturation.
Yes, ma'am.
And you have also mentioned there was no cyanosis, but since you are writing the respiratory system, and these people may, in some conditions, in which condition they can have a low saturation value?
Ma'am, tense ascites can compress the diaphragm above, or ma'am, other cardiac conditions such as cor pulmonale, or if such condition was there, and another cardiac failure, ma'am, mostly right-sided cardiac failure.
Any other?
Any other related with
Actually, I'm
liver?
asking something very specific,
Particular.
and that is why you have to answer that. They
Liver
can
disease.
have many diseases. You can say that he has CLD, along with it, he has something
ma'am.
else. But if your CLD patient has cyanosis, has low saturation, what will you suspect?
Ma'am, another
There's an entity called the hepatopulmonary.
Hepatopulmonary.
pulmonary syndrome, ma'am. Yes.
So,
Yes, ma'am.
just like that, you have to just mention that his saturation was normal. That is the
Yeah.
thing.
Okay, ma'am.
So, just read that part. Okay.
Sure, ma'am.
Another small issue in the history, patient we are discussing that patient is having sleep disturbance,
Yes,
having
sir.
the disease for almost 8 to 10 months. But here CNS function is normal and
No
mental functions
flapping
are normal.
tremor.
So I think in this case, we should think about the minimal hepatic encephalopathy.
Yes.
Yes,
Sleep
yes.
disturbance was there,
Yes, sir.
but we are saying
Grade,
otherwise CNS function, everything
30,
normal.
30 by 30 he has written. MMS
Yeah.
is 4. This is very relevant part that Pradipta has taken up.
He has got the sleep altered sleep pattern.
altered
Yeah.
sleep
He
pattern.
has minimal hepatic encephalopathy maybe.
Rohit, the patient is admitted, still admitted, I think. No?
Yes, yes, yes.
Yes,
So
sir.
he is getting, I think he's getting lactulose and rifaximin also.
Yes,
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 sir.
yes.
That may be a reason he's scored
Maybe better.
better.
Maybe better because of that.
Yes, sir.
Das sir kiba kobo ni gaya. Anything you want to add?
No, this respiratory, as Nandini madam has said, is very important. We tend to overlook it.
Yes,
There are this hepatopulmonary syndrome and portopulmonary syndrome. They have got no specific treatment. That is the problem. They will have to live with that hypoxemia and shunting of in the chest of venous blood going into the arterial system. So these are nothing but collaterals which open up in the presence of high portal pressure, and that is why they need also some intervention, drastic reduction of portal pressure.
Okay, Rohit, go
So
ahead.
proceed.
Yes. So my final diagnosis is this is a case of liver cirrhosis with decompensation in form of ascites without any history of upper GI bleed or encephalopathy or acute kidney injury, most likely due to ethanol intake, sir.
So here you will have to add minimal hepatic encephalopathy as sir was telling. Right?
Yes.
And with portal hypertension, you can add, though you have mentioned decompensation in the form of ascites. Yeah. So,
How do you know this is cirrhosis? What is cirrhosis actually? It's a chronic liver disease, but what is cirrhosis?
Sir, functional and sir, architectural deterioration of liver parenchyma, sir.
That occurs in F2 fibrosis also.
Yes, sir.
Cirrhosis is basically a pathological, histological diagnosis.
Histological. But I said chronic liver disease, decompensated. Chronic liver. It would have been better.
Yes, yes, ma'am.
Bhaskar?
Hello,
Sir.
Chairperson. May I pass a comment?
Yes, sir.
Yes.
Most welcome, Partho sir.
Partho sir.
Yeah. There must be in the complete diagnosis. This is for PG students. For complete diagnosis, we should have some etiological diagnosis also. So
Yes.
this diagnosis doesn't tell anything about
He has written
etiology
due
of the.
to ethanol. He
Yes,
has
written as ethanol, due to ethanol.
most
Oh,
likely
it,
due to ethanol.
now
Yes.
here final diagnosis, is it written over there?
Ah,
It's
Yes,
like,
yes.
oh, I didn't go to that. I'm sorry. Okay,
Yeah.
okay,
Okay, sir.
okay.
Don't be sorry, sir. Your comment is very valuable.
Very important.
Go ahead, Rohit.
Next step is we have to do workup for this patient, sir. We can check for CBC and coagulation profile, the liver function test and renal function test, urine examination, stool for occult blood, ascitic fluid analysis. We can go for radiological investigation such as ultrasound or upper GI endoscopy. We can check for fibroscan to check the stiffness of liver, sir.
Rohit, in this patient, we don't go for fibroscan because he has got the significant ascites.
Yes, I think.
Yeah.
Yes, sir. Sure, sir.
Ultrasound is sufficient in this. There's no point of going for fibroscan.
Oh, okay, sir. Sure, sir.
Rohit, so this patient was having pallor. In CBC, what do you expect?
Sir, in chronic
CBC
liver, yes,
and
sir.
peripheral blood film. So what do you expect?
Sir, anemia, pancytopenia, megaloblastic anemia. There is some specific finding in peripheral blood smear, sir. We can get a spur cell, sir.
Yes.
What about the MCV?
MCV actually raised, sir, higher on
Yes.
the patient.
In this context, can you tell me that is this change megaloblastic in liver? Is it a megaloblastic anemia that they have?
Maybe, ma'am,
No,
because
there is a
multiple
difference
mutation.
between macrocytic anemia and megaloblastic anemia.
Yes, ma'am.
So, which one do you think happens in the chronic liver disease?
Macrocytic was there, ma'am. Actually.
So, in megaloblastic, you will get the changes in the bone marrow,
Yes, ma'am.
large megaloblasts, and there will be hypersegmented neutrophils
Neutrophil, ma'am.
in the peripheral blood,
Peripheral blood
which is
smear.
characterized because of the B12 deficiency.
B12 deficiency.
But in this patient, because he is a chronic alcoholic, so he
Yes,
may be having concomitant B12 deficiency. He may be.
yes, ma'am. Maybe.
So the CBC here is important to look with the peripheral smear whether he has segmented, hypersegmented
Neutrophils.
neutrophils or not.
Yes, ma'am.
Do you know when will you say significant hypersegmented neutrophil? When will you say it is hypersegmented neutrophil?
More than 5, sir. It's there, sir.
5 what?
What?
And
At
that,
least
Segments.
yes, sir.
Yeah, at least 5% should have 5 segmented
5
neutrophil,
segments.
or at least single more than 5 segmented neutrophil in the
Yes, sir.
peripheral.
Sir.
Okay.
So now we proceed to the complication of chronic liver disease, sir. Most common complications are variceal bleed. Patient may go into hepatic encephalopathy, spontaneous bacterial peritonitis, hepatorenal syndrome, or hepatopulmonary syndrome, hepatocellular carcinoma, or refractive ascites, sir. So,
When will you suspect that a patient of chronic liver disease is going towards hepatocellular carcinoma?
sir, there is in decompensation, sir, severe hepatocellular damage. Yes, sir. The patient shows other signs of jaundice or.
Bhaskar, can you throw some light?
Yeah. So, whenever a patient with liver cirrhosis with portal hypertension suddenly deteriorates, there may be acute decompensation or sudden deterioration. We'll think about hepatocellular carcinoma. Like he was going stable with ascites, there's sudden increase in ascites requiring frequent large volume paracentesis, or he may develop jaundice, or he may develop some other complications, sudden deterioration of his stable condition. We need to think about development of underlying hepatocellular cancer. It is very important.
Sir.
And pain in the abdomen.
Pain.
Pain in abdomen.
And while you aspirate the fluid, it will be hemorrhagic.
Hemorrhagic.
Yeah.
Sir.
Go ahead.
Sir, due to portal hypertension, sir, there is increase in pressure in the portal venous circulation, sir. That may lead to the varices, sir. We can now go with management of variceal. First is we have to start with initially we have to stabilize the patient hemodynamically. After stabilization, go with the vasoactive drugs, sir, and then immediately, if vital are stables, we have to go with the endoscopic treatment, sir, such as band ligation or sclerotherapy. And if these endoscopic measures are failed, then we can proceed to TIPS, jugular intrahepatic portal systemic shunt. And even after TIPS, the bleeding is non-controlled, then we can proceed to surgery, sir, further. And we should always give antibiotics in that patients also.
What antibiotic you will like to give?
Sir, we can go for third generation cephalosporin, sir, or can give fluoxetine, sir, not floxor.
Ceftriaxone
Why do we give antibiotics?
Sir, they're likely to precipitate, sir, or more decompensation, sir. Patient may goes into spontaneous bacterial peritonitis. And
Okay. And
sir,
you have written octreotide decreases portal pressure in the management of varicose bleeding.
yes,
I
sir.
think this is a less efficacious than terlipressin.
First line is, sir, V1 and sir, vasopressin, sir. Terlipressin, sir. Vasopressin.
If
Terlipressin,
not
sir.
available because of
Then
cost
we
or
can
the octreotide.
somatostatin and all, sir.
Okay.
Sir.
Okay. Then who are the patients where you suspect that there is varices which are likely to bleed? Because it is an invasive procedure. So
Yes, sir.
do you have any armamentarium in your hand which is non-invasive, but that can lead you to suspect strongly that there is a varix, or it can lead you to suspect that there is unlikely to be any varix?
without going for endoscopy.
Without going for endoscopy, because it's expensive and not available everywhere.
Radiological, sir, CT angiography we can plan, or
That is even
tagged
more expensive.
RBC, sir.
No, that is even more expensive. Okay.
Oh.
Very simple. Two things you can do. You can look at the platelet count.
Yes, sir. It can, sir.
And you can
Thrombocytopenia.
also, yeah, and you can also look at some biomarkers like FIB4 or even
Yes,
AST by ALT,
yes,
if I'm
sir.
not wrong, and they can say that they're unlikely to have varices.
Sir.
Okay.
And one more thing that we can suspect clinically whether patient is having varices or not through your anterior abdominal wall, the dilated tortuous veins over there, how
Yes, sir.
much they are dilated one, and as also the past history of upper GI bleeding leading to melena or hematemesis, how much frequent they have been in last 1 year. You can little bit guess clinically bedside whether patient is likely to have varices over there which can bleed.
Or a patient who is having also associated hemorrhoids.
Yeah,
Oh,
yeah,
yes.
yeah. Yeah,
Yes,
very good.
yes. But there is a caveat. As Nandini madam has said, that there are some other causes of some symptoms of chronic liver disease. Same is with GI bleed, because these cirrhotic patients are very much vulnerable to develop peptic ulcers.
Yes, sir.
Okay, peptic ulcers. So we have found a lot of people CLD with decompensated cirrhosis coming and getting an endoscopy done. There is no varices, but there is a peptic ulcer.
Yes, sir.
Okay, so that should be kept in mind. Just to, but first diagnosis in a bleed of a CLD, definitely decompensated, ascites, edema, everything. So that has to be varicella unless proved otherwise.
Yes, sir.
Okay, Rohit, go ahead. We'll have to finish within 7
Oh,
8
yes.
minutes.
Yes.
Next is ascitic fluid analysis, sir. So we can check for SAG ratio, sir. Ascites is accumulation of fluid in the peritoneal cavity. List
I think, Rohit,
1000
you
ml
can
of.
cut short this part.
Yes, sir.
Yes.
Because we don't have time. It is already more than 1 hour.
Yeah, we can go ahead. You
Sir,
can just cut short.
in
jump.
normal
No.
peritoneum, we can check for SAG ratio, sir. Serum albumin minus ascites
No,
gradient.
we don't have to
The known facts.
पास कर दो उसको पास कर
Okay,
दो
sir. Sir.
पास
Sir.
आगे जाओ. Go ahead.
Next is how we diagnosed SBP, the spontaneous bacterial peritonitis. We can check for counts in ascitic fluid. If the neutrophilic count is more than 250, and if any one organism can be found, so we can call it SBP. Most common organism are E. coli and Klebsiella, ma'am. If multiple organisms are present, then we have to rule out the secondary peritonitis. And in
When did you
treatment,
suspect, Rohit? When did you suspect SBP?
SBP, sir. If patient present with the pain in abdomen, sir, with the sudden decompensation of liver disease, and may associated with fever.
Diffuse pain abdomen and associated fever.
Yes, sir.
First diagnosis is always SBP. When do you collect the fluid?
Before giving antibiotics, sir.
In the casualty itself or in
Yes,
the
sir.
OPD itself. Okay. And
Yes, sir.
bedside inoculation, you must mention. Okay. And being a PG student, you will be asked, why 250? Why not 240? Why not 500? Why not 125? What is the reason for 250? And how to differentiate it from your traumatic tap?
Sir, in traumatic tap counts may be more than 250, but culture is negative, sir, in that case. For SBP, counts and both culture should be positive, sir.
Any
No,
other way?
SBP has got several types.
Yes, sir.
Non-neutrocytopenic, or
Yes,
it
sir.
will be
Culture
culture
negative.
negative also.
Yes, sir.
But anyway,
I think most
Polymicrobial
important point
and
is that whenever a patient comes and readmitted in the hospital, we would like to see what is the reason of readmission.
Yes.
Is it an infection?
Correct.
Is it a new malignancy? Is there any
Yes, sir.
super infection like hepatitis A or E? Because A is increasing in our country now. Or is there any other, say, SBP or any
Yes,
other
sir.
second, as Dr. Nandini was talking about, this thing, cirrhosis associated immune deficiency state and tuberculosis. So I think
Yes,
that is
sir.
the most important. This patient is readmitted. Our job is to see what is the cause of sudden decompensation or sudden readmission. That is our point of discussion here.
Yes, sir.
Yes, sir. Oh.
Hello.
What is the cause of readmission in this case? Rohit, what do you think?
Patient presented with, sir, since last 1 month having decreased urine output, sir. So
Okay.
we can suspect, sir, maybe patient having
AKI.
AKI or oligonucleosis. Yes, sir.
There is a large volume ascites also, isn't it?
Yes, sir.
There is a sudden increase in the ascitic volume.
Yes,
So you have
sir.
to see what is the cause of increase of the ascites in this particular patient. Is it SBP or something else?
Yes,
Right.
sir. Sure, sir.
Next.
These are some common precipitants of hepatic encephalopathy, sir. Most common is drugs, sir. Benzodiazepine, narcotic drugs, overuse of diuretics. Some compounds such as high protein intake, GI bleed, infection, constipation can lead to increase in ammonia production that further precipitate the NSAP, sir. Dehydration, patient may be having history of severe vomiting or diarrhea, sir. That can lead to dehydration or electrolyte imbalance, sir. Most common is hypokalemia, other metabolic alkalosis, massive paracentesis, or maybe hepatocellular carcinoma, sir. These are some.
But our patient, this
Yes,
patient in question, you have said that he has no features of
uh,
encephalopathy, though there was some sleep disturbance.
yes, ma'am.
So let us discuss, if we take this patient in question, let us discuss that what parameters we should be very cautious about to prevent readmission in this patient.
Ma'am, patient was mostly discharged on diuretics, ma'am. Maybe their overuse of diuretic and compliance of medication, ma'am.
Yes. So what was, we have to see the albumin level, because here comes the role of some prophylactic medications in case of chronic liver disease patients. Prophylaxis for SBP,
Yes, ma'am.
prophylaxis to prevent further bleeding from the varices, because these are the causes why he will again come back to you.
Yes, ma'am.
He will come back with a SBP. He will come back with a hematemesis again. Maybe
Yes,
he
ma'am.
will come back with this hepatic encephalopathy. So you have to check whether you have given adequate lactulose to him and prevented electrolyte disturbances, etc. So let us discuss in that fashion. Let's
Yes,
see
ma'am.
what is coming after this.
After this slide, ma'am, these are some hospital management, what we can do in hospital. Advise patient to restrict the salt intake, ma'am. Use of diuretic, we can use spironolactone along with loop diuretics such as furosemide. Large volume Yes,
When
ma'am.
will you think of loop diuretic? Because you have to be cautious about the use of loop diuretic in CLD patients. So what is
Yes,
the
ma'am.
implication?
Massive ascites, ma'am, along with other volume overload sign such as pedal edema, ma'am.
Tell it.
Then we can add, ma'am. And adequate weight loss was even after giving single drug such as spironolactone, adequate weight reduction was not done, ma'am.
What
And
is
we can,
adequate? What is adequate?
sir,
Targeted.
per day we have to target, sir, weight loss. If usually it's less than, sir, 1 kg per day, sir, in massive overload state, sir. And normal patients 0.7 or 0.8 kg per day, sir. Around
No,
700 to 800.
no, Rohit. One
Sir.
is patient is only ascites. Another
Yes, sir.
patient is having ascites with
Ascites
edema.
with other. Yes, sir.
Edema.
If
Edema.
only
What?
ascites, 0.7 kg per day, sir. Around 700.
Half a kg. Half a
Yes,
kg
sir.
per day is the target.
Yes, sir. Half a
And
kg.
if there is ascites and edema,
Then we can go for 1 kg, sir, around 10.
yes.
Maximum 1 kg per day.
Yes, sir.
With edema, without edema, 500 gram per day maximum.
Sir.
But normally, Rohit, what do we do? If we start with, suppose, spironolactone, we'll check his weight actually. We do not suddenly change the diuretic dose or add another one. So if there is
Potassium level.
undesired weight reduction, like if there is less than 800 gram of weight loss within a period of four days, or less than 2 kg in 7 days, then we need to
Yes, sir.
add loop diuretics like furosemide.
Yes, sir. Yes, sir.
Yeah, that's a general rule.
Hmm.
Yeah, next.
For readmission prevention, sir, we have to treat the underlying cause, not only the fluid, not only the symptom. We have to give a proper counseling to the patient about medication, how to take it, and explain the use of diuretic, a proper diet, other warning signs, and ask the patient to came for regular follow-up, sir.
What diet will you advise?
Uh, Sir, in cirrhotic patients, protein-rich diet we usually advise, sir, with salt restriction.
How much protein will you advocate?
Sir, in that patient, 1.3 to 4 gram per kg, sir. Usually.
4 gram.
No, sir, 1
2.5
to
gram.
2, we are 1 to 4, sir, in that range only, sir. More than normal individual, sir.
And calories?
Yes, sir.
How much calories?
Sir, should be
Yeah,
around 2000 to
No, that depends on the body weight.
Body
actually.
weight.
Okay.
It's based on the body weight.
Okay.
Sir,
So will you give low calorie or high calorie diet?
sir,
These are important, very
yes,
important.
yes, sir.
Nutrition is very important part because this
This
is the
patient has
thing.
got very low BMI, so
Yes.
nutrition should be very good.
Yes, sir.
And late evening high carbohydrate diet is one of the most important things that we tend to forget.
Yeah.
Late
Yeah.
evening high calorie diet, because the liver is cirrhotic, fibrotic. There is no glycogen reserve.
Yes, sir.
So people at 2 a.m., 3 a.m., they become hypoglycemic, which can
Hypoglycemia.
kill the patient, this patient, because alcoholic and has developed liver damage. So cardiac damage is also there. There may be hypoglycemia, can cause some cardiac arrhythmia. Patient may die, been died.
Yes, sir.
So tell the patient that if you wake up at night, okay, to go to the toilet. Most people go to the toilet at night once at least. Then you open your fridge or whatever, eat something, and then go back to sleep. So these are small things, but they make a lot of difference.
Yes.
Okay. And about the protein, high protein diet. Even
Yes,
if he has got hepatic encephalopathy, you give high protein diet. There is no Bhaskar.
Yes, sir. So 1.2 to 1.5 gram per kg body you have to give.
Minimum.
Minimum.
Yes, it has to be
And calorie should be 35 kilocalorie per
30
kg body weight
per kg
Yes,
body
sir.
weight per day.
per day.
Sir, there is a concept nowadays. What about the egg yolk in
Mhm.
patients with egg yolk in patients with chronic liver disease?
A young
Egg
Egg
yolk.
yolk.
Egg.
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 egg yolk.
Yes, sir.
Let him eat anything. He is not going to survive for so long. Ask him to take food, tasty food. And there comes that salt restriction. Many patients, they
What
complain
we
about
do, sir,
salt restriction.
what we do, because we have seen those who are non-vegetarian,
Yeah.
if somebody takes a fish, he will take only 30% out of it.
Yes.
Even chicken, sometimes it is not, palatable or may not enjoy the chicken. Most of the time, cirrhotic patients, they do not enjoy chicken. Even if they take it, it is only around 30 to 40%. So
Yeah.
best protein is the egg protein. Take at least 3 to 4 eggs per day until his sarcopenia is covered. I think the best advice, simple advice. And second is salt restriction. Third is fluid restriction. And to see whether there is any change in behavioral things. If we can see these simple things, and what that Anupda was very correctly saying, that night starvation, that should be avoided by at any cost. Otherwise, you will lose the patient. Patient will develop sarcopenia, and he will develop frequent hepatic encephalopathy. Because one of the important causes of frequent hepatic encephalopathy is sarcopenia. We have to stop it by any means.
Yes.
Otherwise, then
Yes.
we can
Yes,
reduce the
yes.
burden of frequent hospitalization.
And the mortality is also increased in sarcopenic patients up to
Yes.
40% more than non-sarcopenic patients.
Yes.
It's very important.
Yeah. So one very important point is the palatability of food, sir.
Palatability, yeah.
So what happens when we advise low salt diet? So definitely the food becomes tasteless.
Little taste.
So we need to add some additional thing that can increase the palatability of the food. That is very important. That part we normally ignore actually. But we need to understand, we need to make them understand, their family members, that add something in the food which increases the taste without affecting the salt content. That is very important.
Yes.
Another
Correct.
important
Kari pata and
issue.
dhaniya pata.
Another important, I attended one meeting by Professor S.K. Sarin sir, and he was telling that the egg yolk contain high amount of methionine, which is very much protective for the liver. So he is recommending that we should advocate rather giving more egg yolk.
So actually, I have a question. Whether egg yolk increases blood cholesterol or not, that is very important thing actually.
Yeah.
It
It
is
is
yes.
a debatable question.
It is not.
But here it is, in these particular cases, I think we should advise a whole egg.
Yes, whole egg.
Whole egg should be given. No restriction of egg yolk and other thing.
Okay,
Yes.
we'll have to end it up. So, Rohit, go
Yes,
ahead.
sir. So next, most common patient-related factors are alcohol relapse, poor compliance, missed follow-up, inadequate diet, and poor awareness, sir. Some disease-related factors are the complication associated with the DCLD, sir. So next is how we can prevent the readmission. So ask patient to stop the alcohol completely, do a counseling proper and family support. Next, take medicine correctly at adequate time, lactulose if needed, and do not self-stop the medication. Control ascites at home. At we can advise low salt diet, daily weight measurement, leg elevation or water restriction if hypernatremia is there, and proper follow-up within 7 to 14 days with the liver function on and electrolyte reports.
What
And
about the
schedule.
beta blocker? It is not written. The
Pardon?
beta blocker.
Yes, ma'am. We can give non-selective beta blocker for all patients until and unless other signs of ma'am SBP or other findings. In that case, patient we usually avoid.
You know how we
Stop.
titrate the beta blocker dose?
Ma'am, we go with carvedilol, ma'am, or propranolol.
No, no.
How to titrate the
How
dose?
to titrate the dose? You have to see whether 25% of
Heart
the
rate. Basal
baseline heart rate
Baseline.
has
Yes, ma'am.
increased.
Heart rate, target heart rate is 55 to 60, ma'am, with the blood pressure 100, ma'am, systolic blood pressure.
Yes.
Mean
Okay.
arterial pressure also.
Yes, sir.
And you should also write up in the follow-up, early follow-up, okay? But there is something known as surveillance.
Yes, sir.
Okay?
Cancer surveillance.
That is important. Just to prevent hepatocellular carcinoma. That is very important. It's increasing.
Yeah,
Yes,
he has
sir.
written, sir.
Huh?
He has written.
That he has written.
Fifth point.
Scheduled paracentesis with variceal and hepatocellular carcinoma surveillance, sir. And advise patient to go for transplant if he is eligible, sir, as early as possible, sir.
Okay. So next.
And next are some red flag sign. You have to tell patients that if these symptom appears, you have to come for follow-up, come for checkup at urgent basis, such as there is more increase in abdominal distension with decreased urine output. If fever appears with pain in abdomen, patients having some confusion or altered sensorium with episode of hematemesis melina or any spontaneous bleed from any other sites, if rapid weight gain is there. So we have to advise patients to monitor for any red flag sign or also to the family member also.
Yes, 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 yes.
The main take-home message, I guess, from my side is that DCLD readmission is often preventable, and at the time of discharge, we must advise patient or patient party regarding the medication use, the proper diet, lab investigations, and routine follow-up. So the main goal of us is not just to discharge the patient. We have to give him a long-term care, sir. Even after discharges, we have to make sure that patient is stable at home also, sir.
So the summary is when such a person comes with for readmission, you have to think of three things. Number one, is it falling under the natural history of the cirrhosis of liver, which is now reached a point of no return, number one, or is it an acute decompensation, number two, or it is an acute on chronic liver failure.
Sure.
Okay, because all these three things have got different types of long-term, I mean, in hospital or the level of mortality. So am I right?
Yes, sir. Yes, sir.
Yes, sir.
It's very difficult condition. And we only manage the liver, albumin-DDA, toliprecin-DDA, AKI, asenine, you just see, but hepatorenal syndrome term is not used nowadays because they have changed everything. Any kidney disease related, I mean, present in the cirrhotic patient is a kidney injury, just a kidney injury. It may be pre-renal, it may be renal, it may be post-renal, even obstructive uropathy. That's becoming very common. And what we have seen, we did some studies here, that whenever we get SBP or TENS ascites, there is always that element of kidney injury in that particular patient. But we don't give any importance to that. I think that should be more thoroughly evaluated. And in alcoholic patients, the cardiac system.
Thank you, sir.
Thank you very much.
Nandini madam, can you take few minutes, because there are some questions in the chat box.
Yes, the panelists, sir, Dr. Anup, everybody is here, so some of them can
Just
be.
we'll try to.
Yeah.
One question is from Neha Kumari, Dr. Neha Kumari. Why do some patients with severe portal hypertension never develop ascites?
It's a very good question. Yes.
The cause of ascites is not only portal hypertension, but it is the splanchnic vasodilatation which is the reason. And all portal hypertension patients may not develop splanchnic vasodilatation, and rather it can be vasoconstriction, or there can be other factors which is causing splanchnic vasoconstriction. And there are other precipitating factors. If these are not there, even patient with clinically significant portal hypertension may not develop ascites. The ascites is a feature of decompensation. So CSPH, clinically significant portal hypertension, not equivalent to decompensation. So patient may even have fibrosis, even may have cirrhosis, but may have clinically significant portal hypertension, but decompensation may not be there. And that's why patient may not develop ascites.
Thank you, sir. Thank you. So another part of the question, of the same questionnaire, that if fibrosis regresses, does the portal hypertension also disappear completely?
Yes.
Has to.
If fibrosis regresses, some amount of portal hypertension can be regressed. It is always evident by measuring the waist pressure. You can see that yes, it is regresses. Even simply terlipressin. Why do you use terlipressin? Only because to reduce the portal pressure. So it can be reduced. No issue.
She is again asking, does the serum ammonia level always correlate with the severity of hepatic encephalopathy?
No.
Not exactly, probably. Not
exactly.
Or albumin can worsen hepatic encephalopathy. Can albumin worsen hepatic encephalopathy?
Not
Usually
always,
not.
but yes, if it is if the pressure is high and because albumin can increase the blood pressure, that time one can have symptoms or behavioral abnormality can increase.
Yeah. Especially in cases of portal hypertension bleed, we have to be careful with albumin because it might increase the portal hypertension.
Right.
Yes.
That's why even in varicose bleed, we do not use albumin randomly. We are very cautious in giving albumin if there is varicose bleed. Rather, it should be given in a restricted manner. Otherwise, it can increase the bleeding.
Yes, sir.
One should be cautious.
She has again asked. Yes, sir.
And also, recently, the albumin therapy has undergone a little bit of scrutiny in the sense that many of the albumin which are infused in a diseased fibrotic liver becomes oxidized albumin.
Yes.
So this oxidized albumin is more toxic to the liver than the normal person in other situations. So this the oxidation of the infused albumin is now being recognized properly, and we do not know who are those patients who will not benefit or rather worsen with sometimes with albumin infusion.
Thank you, sir.
I think two important indications are: one is large volume ascites, second is AKI, where albumin is we use more. More.
Yes.
In other conditions, what should be very restricted.
With spontaneous bacterial peritonitis.
Right.
SBP also, yeah.
What is it? What about hepatorenal or hepatorenal syndrome?
Yeah, it's given. It's given along with terlipressin.
Yeah.
And if we don't have terlipressin, we will go to octreotide. If we don't have octreotide, we will go to NORAD.
Okay, sir.
And albumin infusion.
So the last question is, again, she has asked the question, Dr. Neha Kumari. Can a late evening high carbohydrate diet be recommended in a patient?
Dr. Anup sir, he has mentioned that.
Very nicely described. Yeah.
Yes.
Yeah.
that was addressed.
Yeah. So with this, we end up the question answer session. So final remarks from the panelists in brief.
Pradeep Babu, you start.
No, sir. No, nothing. I think readmission now in 2026, cirrhosis is preventable and fibrosis is reversible, and clinically significant portal hypertension causing complication can be reduced or decompensation can be recompensated. So now cirrhosis or decompensation is not the end of life, and every patient may not require even portal liver transplantation. Though we have got facility of liver transplant in India, it is much more than any other country. But we have got other facilities also. So it is not the end of life. We have got many options to reduce the mortality and morbidity.
Thank you, sir.
Thank you. Thank you.
There is one more question just arrived. Should I read out?
This should be the last one.
Yes, sir. Role of steroid in CLD with severe alcoholic hepatitis.
Yeah.
If it is alcoholic hepatitis, the role is there definitely.
There.
And another is autoimmune hepatitis. There's a two condition where cirrhosis is definitely indicated. But in case of now alcoholic hepatitis, there are other molecules are there now. Newer molecule has come, which may in future take the place of steroid. But steroid should be given if discriminatory factor is more than 32. Steroid should be given. Provided there is no infection or severe infection is not there, you can always give steroid. Or rather that is the only mode of treatment.
And in autoimmune hepatitis, Pradeep Babu has said that autoimmune hepatitis can come with a flare.
Yeah.
And cause sudden decompensation. So, and it may be life-threatening, and there you can use corticosteroids. Bhaskar?
Yes, sir. So basically in alcoholic hepatitis, we have to be a bit careful also with steroids. But because in some patient with severe alcoholic hepatitis, steroid may deteriorate his condition actually.
Yeah.
Yes.
If the DF is very high, suppose more than 100, in those patients, we have to be very careful in starting steroid, rather not to give steroid in those patients actually. If they very
it has been shown that above 52 discriminant factor, steroid can cause harm.
So it is better not to give.
Better not to give them.
We can follow the Lilly score also there.
Yes.
Oh yes.
So last comment from Nandini madam.
So this was a very interesting and exhaustive discussion about chronic liver disease, and I thank our moderator, Dr. Dijen Dash, and our esteemed panelists, Dr. Anup Kumar Dash, Dr. Pradeep Bhovik, and Dr. Bhaskar Jyoti Borua. And I'm sure everybody is much benefited by this discussion. And I think Ashutosh, Dr. Ashutosh Chaturvedi, is he here?
Yes, ma'am, I'm here.
Yeah,
and
so
I want
so I will give the mic to you so that you can ultimately wrap up the whole program.
The discussion has been so engaging that I couldn't leave. I left in between,
Yes.
but I rejoined and I couldn't leave since last 15-20 minutes. So I congratulate all our esteemed panelists and would like to comment on that question, that interesting question, that why some patients do not develop portal hypertension. So as Pradeep sir already answered beautifully, but I think the experts will agree that in some patients, especially with non-cirrhotic portal hypertension patients, the synthetic function of liver remains good. So that is one of the points. And another one, as Sir has explained, that is splanchnic vasodilatation in the circulation that reduces the effective arterial volume and triggers the fluid retention. So if this circulatory function is mild, so ascites may not form. So I think these are the two main reasons for that. What other things have been brilliantly explained by our experts. So I thank you everyone for being part of this highly engaging and academically enriching ICP clinical case dialogue. And I sincerely thank our moderator, Dr. Dujen Das sir, convener, Dr. Nandini madam, all our esteemed panelists, Dr. Anup Kumar Das sir, Dr. Pradeep Kumar Bhaumik sir, and Dr. Bhaskar Jyoti Barua sir for an outstanding and highly engaging clinical discussion, and also to Dr. Rohit, our case presenter, who has been grilled by everyone in this last 1.5 hours. So, sincere gratitude from ICP, and thanks to our Honorable Dean, Dr. Girish Mathur sir, for giving us this opportunity. I can saw that almost 50 delegates are still logged in till 10 p.m. So that reflects the highly successful nature of this case presentation. So thank you so much, ma'am, and thank you all respected dignitaries.
Thank you. Thank you. Good night. Thank you very
Good
much.
night.
Good night.
Good night.
Thank you, Rohit.
Thank you so much, sir.
Thank you.